usually it means the patient's not taking the drug. So I think you've got what I would call a serial offender here, who just repeatedly won't apply the treatment. And the fact that he's a male, in his mid-teens, age 16, this is probably the most difficult age in many ways. They're notorious difficult to manage. So I don't, the guidelines do not address this. Don't have somebody who won't do what they're told. Which means you've got to then make your treatment what we call bespoke. It's like having a suit fitted. We'll make the treatment fit the patient. They not make the treatment fit the guidelines. And so the question with this one is, can we make the treatment fit the patient better? The guidelines have failed, clearly. So looking at that, is there anything we could do different? There's one thing I guess you could argue that would have been worth doing, and that is trying stomach ulcer early. But it looks as though that wouldn't have worked because the patient wasn't going to take it anyway. So in a sense, you could argue that that was an experiment to be done, but then if it's apparent the patient's not taking it, you might as well stop it. I wouldn't prescribe 60 milligrams a day to a patient at great expense when they're not taking the stuff. If it's from the stuff, that's why it's the first time we stop it. So that then brings us to the phosphate. Now, phosphate control, I think, is probably the central problem. And you've chosen to use Renagel, is that right? Renagel is the least potent of the phosphate binders. It's got a good safety record, but it is the least potent in terms of phosphate binding capacity per gram of medication. I don't know what alternatives you have here. Of course, the best phosphate binder we all know is alidinol. We're not going to use that in this situation for obvious reasons. But there are other ones that are more potent than Renagel. The two I'm thinking of particularly one of them you probably have lanthanum. Do you have lanthanum carbonate here? And I think it would be well worth trying that. Use the money you save on the silica calcite. You use the lanthanum. Purely because, in my experience, you do sometimes find the patient will take one phosphate right over the calculator. So it's worth reading the changes. They don't make that you should change phosphate binders. It's a cure for first place. That's one thing I would do. But then ultimately, I think here, you're going to have to, as it were, take the patient's decision forward and do something that's not here, i.e. do it. And because this paradigm is now so bad that quite a bit of the phosphate problem is not related to diet anymore. It's related to phosphate coming out of the skeleton because of those phosphate functions. That you can deal with personally, if I would say, yes, subtotal paradigmatically, subtotal, not total. Total in this would be an absolute disaster because he's not compliant with treatment, then he has no PTH, he'll be going around with a serum calcium of 5 all the time, and he'll be doing technique, fitting, cardiac rhythm, as you name it, because he won't take his medication. So I would say that this patient needs a subtotal paradigmatically, accepting that that's not an ideal solution, but it's probably the best you can do.
So guidelines don't treat patients.
Treat
patients based on guidelines.
Exactly. You treat the patient, not the guidelines. And a colleague of mine, who I used to work with, got a very nice slide which shows a row of patients of different sizes, shapes, some men, some women, some black, some white, some fat, some thin, it's a whole range. Simply, bottom it says, guidelines, populations, and doctors are patients. So I think that's the issue here. Don't be frightened to deviate from the guidelines. Guidelines are just that.
Just organizes our thinking at the beginning of the case.
It's not about
should we individualize everything for our patient. I think this adolescent boy is resilient and he can do everything. And I think one of the tools to be followed in such scenarios is to consult the patient, to sit with them, to give you other alternatives with the best of his preference to be followed. And case, I want just to say that we should strive against the organic things like Ebola, and processing. All these should be omitted from our schedule because there is no value from the nutritional point of view, and the absorption from the organic phosphate is 100%. Thank you very much for your case, and thank you. These are the cases. We move to Dr. Shamamar. Dr. Shamamar is a consultant of the Georgia Analysis at the Georgia Medical Center, and he has one case for the one case presented in 5 minutes, followed by questions. So only one question at the end after 5 minutes. Just a moment. Because I remember a very important question to the Professor Cunningham regarding your aspects or your tendency for bilateral integrating referred to the syndrome patients. Do you have any recommendation or with or against bilateral integrating the syndrome?
Well, I don't personally, I've not been involved in doing a bilateral, or recommending a bilateral breast for about 25 years. What we tended to do is to effectively do a medical nephrectomy by putting the patient onto NSAIDs and then creating some body contraction dialysis. And that will normally cause the kidneys to shut up completely. And we have done that from time to time, and usually that's good enough, provided you no longer value the kidneys. You've got to be willing to accept that you're not going to have any kidneys. We recently did that on a lady who had FSGS, and she had proteinuria at between 60 and 70 grams a day, which is the highest I've ever seen. I've never seen it that high. She was about 65 or so, she couldn't possibly keep up. And to get her dry enough in order not to be drowning in her own fluid, we had to body contract her so much, huge alpha infusions, essentially gave her away. So we actually gave her anti-inflammatories, ACE inhibitors, and dialysis, and switched the whole thing off. She's much better.
Now we have to go to the first medical for 6 weeks.
Yeah.
If we actually do this only in familial FSGS cases because they are resistant to immunosuppression and there is huge protein rate. They are admitted to time. They have lost a lot of immunity. So if they resist the medical management, we shift to unilateral nephrectomy. And we have 5 cases like this and they survive now without
But as a part of the purpose, I am against this purpose. Because if you look at the very essentially those patients with severe factor and anemia, you will put him in the critical comorbidity. And you may not get in a single effect. This is why I create this debate in the presence of our
there is a protocol in Finland. Because there is Finnish
trial is diagnosed in unit period, and the prognosis, if I know the risk is very bad. I'm talking about an nephrectomy and putting the patient to the nutrition tube and the CKD-MBD, mortality is more than 90%.
May surprise you that the prognosis is not so bad because they do unilateral, bilateral nephrectomy, they do peritoneal dialysis according to their protocol, and they do kidney transplant with very, very low rate of rejection and recurrence, as you know.
If the patient is ready for transplantation,
then discussing they actually, but they have good results actually from the papers. We have a similar scenario because we have familial FSGS account 30% of our total biopsies. They are resistant to all medications, even cyclosporin, acronics, and so on. So we have a clinical step also outside the.
But in this moment, I encourage the use of ACE inhibitors,
Yes, we do.
RAS blockers to the maximum I can. But again and again, I should say to strict or restrict
I
the use of
understand. But my friend, I realize your hesitancy in doing this. I know. But when you are facing a situation like this, you use all your lines, and the patient is heavy proteinuria. What do you do?
Well, I don't think any of these treatments we just heard about work in this scenario. It's conventional to put them on ACE inhibitors and ARBs.
Yes.
I ask the question, why should they work? You've got big holes in the GBM.
Yes.
I cannot see that a medication like a RAS inhibitor is going to make any difference in that, except by lowering the GFR. So drugs that lower the GFR, like cyclosporin in high doses, or RAS inhibitors in the presence of volume contraction, or NSAIDs, then you will reduce proteinuria a bit because you lower the GFR, but you won't fundamentally alter what is a real problem in the GBM, and that's the issue. And sadly, with these bad FSGS cases, you have to lower the GFR to way down, 15, 10 ml per minute before you have a real impact on the protein excretion. This lady I spoke about was not familial, but she continued to put out 60 grams of albumin a day when the GFR was about 20 or 25. So really a real mess. So I sympathise with children being even worse.
Thank you.
Thank you very much. Total pressure. So.
She's a 65 years old lady. She's an autosomal resistant kidney disease. And she was maintained on regular dialysis since 12 years ago. The diagnosis of dynamic bone disease has been made because she has a persistent below pH level below 100 picogram per milliliter, and hypercalcemia, body pain, and low alkaline phosphates. Actually, we don't have very specific alkaline phosphates. It's autism. She was managed initially by avoiding vitamin and dose calcium phosphate and low calcium. From March 2014, a DEXA scan revealed significant reduction of bone mineral density. This for below 5 standard deviation at the ground and below 3.6 at the spine and below 3.7 at the femur. It's 2 millimeters, it's 1.5. It's 1.5 millimeters. Actually, then we thought about femur. It's an anabolic agent for osteoporosis. So it's not anti-resorptive. We thought that it would be accepted in the patient with dynamic bone disease, unlike other anti-resorptive therapy. And actually, it's a potential treatment for dynamic bone disease as proven in small study. At the same time, it's a proven treatment for osteoporosis. So, on January 2014, we started for the 25 subcutaneously 3 times per week after dialysis. Unfortunately, a few months after that, the patient fell and she developed pneumonia fracture. She required surgery. Actually, she did surgery twice, initially by fixation with plate and screw, and then by total hip replacement. The rehabilitation course was lengthy and painful. entered PTH in January 2015, we find a level of 824 that entered PTH immediately before it, 3 months before it was 106 microgram per minute. So we stopped teriparatide therapy after a year, a total of a year. A follow-up entered PTH in February 2015 was 549 microgram per minute. So we have a question. Is teriparatide is an accepted option for treatment for a dynamic core disease? If now the guidelines don't state this, but just small pilots out of 17 dialysis patients that should improve. Where will I use it in such a patient?
Right. So I think it was a reasonable thing to do, but I don't think the way you did it stood much chance of working. Bear in mind that PTH is a peptide, it has a plasma half-life of a minute or two only. It's a very, very short half, rapidly cleaved agent. So in osteoporosis, one is giving a daily injection of stuff, and that appears to be anabolic in normal people. And what you achieve is you basically, at that dose, 20 micrograms a day, you double or triple the PTH concentration in a normal person for a short period of time. That seems to be sufficient to switch on over. Now here, you're going to be doing that only 3 times a week. I don't see that working. And you can say, well, let's give bigger doses. I'm not even sure that will work. Bigger doses then become catabolic when they're high and do nothing as soon as it goes away. So I suspect that if you're going to use PTH in this scenario as a treatment, I would favour giving it as using a subcutaneous as a continuous infusion, like you do with insulin. And I've not seen any reports of that, I have to say. But to me, that's the logical way to do it. Give it a subcutaneous pump if you're going to do it. Untested, needs to be looked at. Now the next question, did this patient have adynamic bone disease at all? The question, and I think that the clinical and biochemical phenotype you described is very characteristic of that. So good chance, I think it's a reasonable diagnosis. Just one question though, what was the treatment the patient had up to the time that you thought that they developed adynamic bone disease?
With the chance for the PTH to close up, just avoid support suppression and avoid calcium.
Sort of before that, during the early phase of dialysis, before you realise that the patient may have got adynamic bone disease, what treatment they started on? Presumably that was after calcidol or calcium binders.
Yes, actually, this patient, the first time we checked the PTH, it was not high. It was that low. Possibly, she has a long history of CKD and she was receiving calcium binders and vitamin D and those. And this makes a lot of suppression to enter PTH.
So the suggestion is that this patient may well have arrived on dialysis already somewhat overtreated and with suppressed PTH and low bone turnover. But I think the phenotype is right though. You've got low PTH, you've got hypercalcemia, despite there being no calcemic drugs, there's no vitamin D, no calcium supplements, that was right, wasn't it? So that all fits perfectly well. And then you have a fragility. Well, we had a fall of a fracture, so we don't know whether that was how bad the fall was, so you can't necessarily call that a fragility fracture, but it's suspicious. And then the surgery failed, not surprisingly, because they did the wrong operation, because they attempted to fix it using in a skeleton that was adynamic. So I imagine that what happened was that the screws came out. And what they should have done would be go straight I think we should have gone straight to the things to say there. One is the denosumab, of course, is not licensed for this clinical scenario. Denosumab has been substantially positive, it's been looked at in non-renal patients, and in the big studies, reanalysis of the tail of patients recruited who had CKD stage 3, the overall recruitment group, showed that it worked just as well in CKD stage 2 and 3 as it did in those with normal kidney function. But it still does not have an indication that level of renal function. Dialysis, like that. I would not recommend doing that here. I think what you need to do is let the PTH stay at a moderately elevated level for a while, and then use that as your anabolic agent. You kind of make your own PTH, and then endeavour gently to bring it down to the KD-go target. She's only just above the KD-go target now. What's the PTH now? Not 500. Okay. So we're 600. So we're all right. I think you're okay there. I would not give denosumab. I would use the PTH as your bone-forming stimulus. Try and keep it in the upper part of that target range. You can keep it between, say, 500 and 700. That would be good.
This patient, she was still in pain for 3 days. With this hospital surgeon, he was insistent of using this was really actually prescribed uric acid for his administration.
So let me.
Yeah.
So I have to say that is the worst choice I can think of. So, well, it's A, bisphosphonate, it's not licensed. There's lots of reason to think that this patient may still have low turnover bone disease. Maybe we have no idea what the skeleton's doing yet. We just do not know whether the low turnover So to give a bisphosphonate is a brave move in the absence of any information. To give the longest acting bisphosphonate to anyway, is even worse. So I would not that. That particular chart, that's critical because if it's the wrong treatment, it will only be around for about 6 months. So you're not stuck with a bad therapy which was going on for years. Again, you have to resolve it here, and also that's the best one for you. I'm not convinced it's the right thing to be doing.
Because of the fact that she still has a line
She still has, may have AMM, she may, we just don't know. Now, is there any way that you can get bone-specific alkaline phosphatase? I think that would help you a bit in trying to decide where you are on the spectrum of bone turnover. PTH is a bit rare, it's not dramatically, it's a moderately rare, but you've almost certainly had dynamic bone disease before. So there's a transition taking place. What you really want to know is what the bone is doing. You can't do a biopsy because it's difficult to do. So it's the next best thing I think is to do versus the bone markers. Well, hopefully we'll have an answer by the time we need the next dose. So I will try and get that extra information before the next dose is due. Keep the PTH at the upper end of the KD-go target.
I think if we visit this case as no turnover or no disease, I think there is no good choice. But if we deal with the case as osteoporosis, there is blood loss, then provide the best choice. So what should they do is, it's an autoimmune disease, but this will be noted by measuring the form of surface. If you find it's low, I think the result is not good. So it's not at all. Generally, the lab is still used to test surface, and you should know well the vitamin D is in normal level, calcium is normal, before giving the result for the patient. But it's a very nice drug in the domain of osteoporosis in general.
And in the early CKD as well.
Yeah.
Early CKD.
Still test surface.
We just don't know. We don't know.
Still test surface for sure. But if your diagnosis and good references and medical disease, I think it's a good choice. Thank you very much for the question.
But I must concede, difficult case. I understand why it's difficult here. So we'll have to discuss.
We have missed the case, but because the presenter has some problem to attend. But the question of the case is, what's your opinion regarding the use of DEXA scan to diagnose osteoporosis in patients with CKD or in the axis? The utility, which is the best advice for us?
Well, up to about 5 years ago, it was thought that DEXA scans, well, so up to about 15 years ago, it was thought that DEXA scans were quite useful in dialysis, and they were used in much the same way as non-dialysis patients. And a lot of doctors, usually not renal doctors, more likely to be rheumatologists or osteoporosis doctors, were basing their decisions in dialysis patients on DEXA results. And it's pretty clear that the predictive value of a DEXA scan in dialysis is very low. It's particularly low with regard to the lumbar spine, which is one of the key sites, of course, that you would do normally. And there may be various reasons for that. One of them is